Okay, we got more than 40 participants, so I think we should get started, especially because I've heard from Jeff that his talk is going to be jam-packed with exciting stuff. So it's a great pleasure to introduce Jeff Newcorn, one of the few Hall of Famers in our department. Jeff Newcorn is a Hall of Famer for CHAD, which is the Children and Adults with Attention Deficit and Hyperactivity Disorder. And he became a Hall of Famer there because of his accomplishments that we all know about in research, treatment, and education for ADHD. Jeff is a professor in our department. He's also a professor in pediatrics, and he's the director of our very successful Division of ADHD and Learning Disorders at Mount Sinai. And he's also the director of pediatric pharmacology for the Mount Sinai Health System. Jeff received his undergraduate medical degree from the University of Rochester, and his adult and child psychiatry training at Tufts. And I think, as you all know, he's a world leader in ADHD clinically, research, mentoring. He's done many critical, pivotal clinical trials. He was on the DSM committee for ADHD. He's an outstanding mentor and educator, has received awards for that as well. And he's really been driving ADHD research and treatment for the course of his career. He also works in aggression and disruptive psychopathologies. I guess I'll say it one more time. He's a world leader and truly one of the stars of our department and of the Northeast, shall we say. And it's a great pleasure. Thank you for agreeing to do this. And I'll turn it over to you.
Thanks, Joe, very much. Thanks for inviting me. Thanks, those of you who are on, for coming. And I'm going to share my screen. And I'm going to go back here. And let's see. All right, we ready? We're good. So this talk is titled "How Do Drugs for ADHD Work?" I hope you'll come to see that it's a little more than about the drugs for ADHD. I hope it didn't scare away people who are not interested in drug treatment. Here are my disclosures. I do have the good fortune to work for a lot of companies thinking about making drugs for ADHD, or those who do. Just tell you briefly about the plan for this talk. Going to review the phenomenology and neurobiology of ADHD just briefly. Going to examine the array of medications currently available, describe their mechanisms through which they exert their clinical effects. And we're going to consider clinical and neurobiological mechanisms related to both core ADHD symptoms and associated features. And I think throughout, you'll see that it highlights differences between the restrictive definition of ADHD presented in DSM-5 and the broader conceptualization of ADHD, which is emerging in the literature. So what's ADHD? It's clearly a condition that's popular and very easy to find good clip art for. You have here the behavioral descriptors for ADHD and DSM, in the two domains, inattention and hyperactivity impulsivity, on the two sides of the screen. And we like to say that ADHD is the tip of the iceberg. And if you look at the criteria, obviously, if you constrict them down and if you only take the text box, you lose some of the richness of detail. But you'll see that they mainly describe behaviors that are, frequent also in people that don't have ADHD. They're certainly much more oriented to child behaviors than adult behaviors, even though ADHD exists across the lifespan. And they tend to be high frequency rather than low frequency events. Now, inside the iceberg, of course, are pictures of impairments that are all associated with ADHD and are all greater in people with ADHD. And although they're not exclusively accounted for by ADHD by any means, And even in ADHD samples, they're greater in people with ADHD and comorbidity. But ADHD in many cases escalates the risk for those rather unfortunate outcomes. Now, I said that ADHD is highly prevalent, and here we list the prevalence across a lifespan. As you can see, 8 to 11% of children, depending on age and gender, it's quite a high figure. And even in adults, now we have very good data from multiple studies showing a prevalence rate of about 4.5% and a very low rate of treatment. Now, the 11% here was from a study that was about 15 years ago. So that's the National Comorbidity Replication. But that's the Kessler study indicated here. And that number is probably still only around 20 or 25%. I thought I would highlight it for the department because I think it's a big issue across the lifespan, and it's not just what's obviously known about kids. ADHD is highly heritable. It's almost as heritable as any condition in psychiatry. You can see the heritability coefficient here as roughly what it is for schizophrenia and bipolar disorder. It's somewhat lower than it is in autism, although I understand that the heritability of autism is dropping a bit as you've embraced the spectrum, broader spectrum. Now, there have been a lot of candidate genes looked at, mainly within the monoamine system and specifically in the catecholamine system, because of what we know about the neurobiology of attention, inhibitory control, and the way that stimulants work. And we're going to talk about that. But these have very small, and they're replicated, but they have very, very small effect sizes. And trivial geneticists would tell us. Now, recently, last year, we had the first successful GWAS study of over 20,000 cases, which identified 12 independent gene loci associated with the disorder, none really of the candidates. And one of the interesting things, there are many interesting things about that study, but one of the interesting things is it shows that the genetics of inattention and ADHD is quite similar to the genetics of inattention in the population, only reinforcing the point that ADHD is a disorder, but it really exists on a continuum. Kurt's been drawing this slide for me and with me over the last 20 plus years. I should really get rid of the build. Anyway, it mainly shows an early and evolving a picture of the neurobiology of ADHD, certainly with a primacy on the frontostriatal networks and regulation through cerebellum and the catecholaminergic inputs. We updated for a presentation on a drug development showing the basically the receptors and transporters involved in the various brain regions and the modulators, all of which are potential drug targets. But as complex as this figure may seem to some of you, it's really very simplistic in terms of evolving understanding of the biology of ADHD. Now, the last slide really showed you the primacy of the frontostriatal executive function circuit. But over the last 15 or 20 years, we have had an expansion of the model of ADHD. And this dual pathway model, I think, is really interesting and important, postulated by Edmund Sanuga-Bark and colleagues. Javier Castellanos was also important in advancing this model. As you can see, the slide shows you, on the top, the neurobiological basis in circuitry, the psychological processes, and the behavioral expressions. And so, on the executive circuit side, we see, as expected, inhibitory control deficits, inattention, and executive dysfunction. And on the other side, on the reward side, we see delay aversion, meaning it's really hard to wait, and delay reward gradient being shorter. That means that you need more immediate reinforcement. Here, think the marshmallow test, right? So you've got to have, and also think about the consequences for behavioral therapy. You've got to have immediate reinforcement. You can't prolong it. You can't wait. And you can see, you can, through both sides, how you would get to the behavioral manifestations of ADHD. Not considering all the options through both the reward and the executive side will lead you to inhibitory deficits. It'll lead you to inattention. It'll lead you to a lot of other issues. And as you can see in the middle of the slide, it'll also might lead you to emotional dysregulation. And we'll talk about that in just a moment. Now, Cubillo and Rubia advanced this model, suggesting the neurobiological underpinnings of the dual pathway model, showing the brain regions and networks that are involved in executive control on the left side of the slide. And the ones that we know and talk about so often in ADHD: inferior frontal cortex, DLPFC, anterior cingulate, and also the striatum and the cerebellum. But over here on the right side of the slide, you see a lot of limbic structures related to affect modulation and control, which we have not typically thought of as implicated in ADHD. So what about emotional dysregulation in ADHD? Well, it turns out that it's quite high, and it's not solely accounted for by comorbidity. And we know that about 30 to 40% of children and adolescents have significant impairments in emotional dysregulation, which might look like rage outbursts, irritability, overreactivity, poor frustration tolerance, susceptibility to anger. So these go a little beyond what we would call a core symptomatology of ADHD into emotional control. And it's interesting because we've thought so much about cognitive control and inhibitory control, behavioral control, right? But we haven't really thought about emotional control in ADHD, or at least in terms of the cardinal description of the disorder. And I might have told you earlier, but didn't, that the definition we have of ADHD has really been with us more or less as is, with minor modifications, since DSM-3 in 1980. And you can see at the bottom of the slide the number of publications that show you prevalence of emotional dysregulation in adults with ADHD. It's quite high. And you see also that the behaviors link very much to mood regulation as well. It's very interesting that in the original conceptualization of adult ADHD advanced by Paul Wender, he really emphasized the poor frustration tolerance and the short fuse and the emotional reactivity. And a lot of people were critical of his original conceptualization, thinking that he really was getting ADHD confused with depression. And that's an interesting and provocative area for both clinical work and research. Now, the conceptualization of emotional dyscontrol also gets, I think it's really nicely illustrated in this figure that was included in a paper that I co-authored with Steve Ferrone and several other colleagues. And it basically talks about basically a bottom-up and a top-down model of emotional control. So thinking about, emotion generation, right? So, which you might consider emotional impulsivity, having too much emotional signal, and strong emotions, and then thinking about a top-down regulation of that, which would be impaired emotion regulation or inhibitory control of emotion, and so-called deficient emotional self-regulation, DESR, as it's been studied by Barkley and Biederman and colleagues. So I think, and we'll talk about this a little bit more. And there you have those names. Now, I mentioned the importance a little of motivation, reward circuit, and motivation is linked to reward. And this figure was taken from a paper that we did with Nora Volkov when we were doing PET radioligand studies of adult ADHD. And it shows that ratings of inattention are correlated with ratings of motivation. And this is on the multidimensional personality questionnaire. And this was true in individuals with ADHD, and it wasn't really true in the healthy controls. And it's a really important clinical point, as well as neurobiological point, because it speaks to something that everybody knows about ADHD, which is that everybody with ADHD can pay attention, and also that everybody without ADHD cannot pay attention. And it really depends to what you're trying to pay attention and for how long. And you'll see that the important implications of this, both in research and in clinical practice, as the talk develops. Now, another important construct to introduce here is the role of the default mode network that has gotten a lot of attention over the last 15 to 20 years. And basically is what you measure when you do resting state MRI. And when we talk about attention and areas that are involved in attention and the so-called executive function circuit, we're really talking about the brain regions that activate when you're doing a structured task. And what we originally called the default mode network is what your brain was doing when it was not doing anything. Although we know the brain never doesn't do anything. It's always doing something. But in the case of not doing anything, it's not doing a structured task. So it's, I think, nicely labeled here as task positive and task negative. And, you know, although you don't want your default mode network to be really active when you're trying to do math problems, it's very nice for reverie, and it's nice for fantasy, and it's nice for also for consolidation. And it may be important in terms of understanding the creative process. So task negative brain regions are very important, but they're not important to getting structured tasks done, and we want to suppress them when we do that. And so this slide kind of summarizes the current view of ADHD: multiple cognitive and emotional processes and interacting brain networks. And so here you have the cortical brain regions, dorsal and ventral attention network. And here you have the subcortical brain regions with the dorsal anterior cingulate and ventral cingulate cortex. And here you have caudate, and we'll talk about the amygdala in a bit, and cerebellum. Here you have the catecholamine networks and their projections. Here you have the executive control network. And here you have the reward network, and then you have alerting, arousal and alerting, and then here you have default mode. So all of these brain processes are implicated in ADHD. And so to briefly summarize this, DSM defines a rather narrow picture of ADHD with a primacy on inattention, even much more so than executive function, which we think of as synonymous with inattention, but it's a more sophisticated and complex construct, and hyperactive impulsive symptoms, but presented in a rather narrowly defined way, consistent with the frontostriatal model of the disorder. Recent models, and certainly a lot of research in ADHD, has highlighted the importance of several other symptomatic and functional domains with an expanded view of executive dysfunction, mood dysregulation, the important roles of motivation and salience. And certainly studies of ADHD pathophysiology are consistent with this expanded conceptualization of ADHD, which has important implications for diagnosis and treatment. All right, so we take a deep breath and we now shift into talking about medications for ADHD and how they bring about clinical improvement. So this is a slide that I've been making and remaking and updating over the last at least 10 years. It basically includes every drug that we have for ADHD, including the ones we're studying. It includes those that are approved, those that are not approved. And it does list them in brand name, I should say, because you would have no idea what we were talking about with these multiple stimulant formulations, except by their brand name. But there is a key using the generic names. Normally, you do it the other way around. But basically, at the end of the day, what do we have? We have two classes of stimulants. We have methylphenidate and we have amphetamine. And we have them in a lot of different formulations that basically relate to duration of activity and how you get it in. So, you know, we have pills, we have capsules, we have beads, we have liquids, we have chewable, we have orally disintegrating tablet, we have a patch. Where's the patch? There it is. And then we have two approved non-stimulant classes. We have atomoxetine or Strattera, and we have the long-acting alpha-2 agonists, Intuitive and Capve, or long-acting guanfacine and long-acting clonidine. And then we have drugs that are not approved. Most of these don't have extensive study. The short-acting alpha-2 agonists do. They were the basis for the development programs for the longer-acting alpha-2 agonists. The tricyclics have a reasonable amount of research as well, and Wellbutrin has multi-site studies in both children and adults, but doesn't have a label and isn't likely to go after one. So what does stimulant treatment do? It improves core. We're going to talk first about stimulants. It improves core symptoms of ADHD with a very high effect size, about as robust as anything we have in psychiatry. But it also provides improvement for a lot of associated features, including behavioral noncompliance, impulsive aggression, social interactions, social awareness, academic efficiency, meaning getting through stuff faster, academic accuracy, not making careless mistakes, family dynamics, improve peer interactions, and self-esteem. So how do they work? Basically, this cartoon gives you a nice illustration. So presynaptic, postsynaptic neuron, synapse. Stimulants block presynaptic transporters that suck neurotransmitter back up into the presynaptic neuron. Atomoxetine or Strattera does that as well. The stimulants do it for both norepinephrine and dopamine, although people talk a lot more about dopamine than norepinephrine. And atomoxetine does it exclusively for norepinephrine, not dopamine. It has a little bit of activity at the serotonin transporter as well. As you can see, amphetamines also block reuptake into these intrasynaptic vesicles. And so you have more free-floating neurotransmitter in the presence of amphetamine, which diffuses out. So amphetamine increases neurotransmitter release, as well as blocking of reuptake. And I see I have a typo there, as many times as I've looked at this. And so, you know, it's basically a schematic. And how do we know this? We know this through some very sophisticated PET radioligand studies. This slide was provided by Nora Volkov, and it shows basically the how stimulants like methylphenidate bind to the presynaptic dopamine transporter. And basically what you do is you give a radioactive ligand that binds to this transporter, and first you give it without drug, and you see the ligand. That's what you're seeing here in the striatum. And then you give drug, and you block reuptake, and you see here, you see much less of the ligand. It displaces the ligand from here. You also can use ligands for postsynaptic activity. Here it's raclopride, and so you can quantify all of this. And in fact, this slide shows you the effect of stimulants on norepinephrine and dopamine transporters, dopamine on the left, norepinephrine on the right. And it shows you that you get a very nice DAT occupancy dose relationship, and that asymptotes at about 50 to 70% DAT occupancy. And it works, and it's right within the clinical range, so about 0.5 milligram per kilogram per dose, about what you want to give for methylphenidate. And you see, this is dose dependent, so this is, I think, 0, 20, and 40 milligrams. You can see you get a nice dose dependent finding. Initially, these studies were done with IV methylphenidate, but they were also done with oral methylphenidate, and it works just fine. Now, you can use DAT occupancy to look at the time course of activity of drugs, like for ADHD, particularly methylphenidate. You could do it for amphetamine too, but you'd have more trouble with the amphetamine. So here, this is a study done by my friend and colleague, Tom Spencer, in Mass General. And here you have immediate release methylphenidate, and here you have osmotic release, so-called Oros methylphenidate, which has a brand name of Concerta. And you can see that this is the PK curve and this is the binding curve. And you can see that how the PK curve is more or less informed by the binding, and shows how these drugs are different and behave differently. Now, a lot of work has been done with fMRI, also structural MRI, but I'm not going to really cover structural MRI today. It's not really good for showing drug effects. Katya Rubia has been one of the leaders in this, and she did a meta-analysis of MRI studies, functional MRI studies, showing mainly the findings both for increased activation in right inferior frontal cortex and decreased activation in anterior cingulate, both of which were, and those findings were for ADHD versus non-ADHD, and then drug versus placebo. So these are the drug effects, and they're reasonably consistent across studies. Again, highlighting the attentional control and inhibitory control improvement that you see with these drugs. But we know that stimulants do more than that. How do we know it? And we know that dopamine transporters are not only in the striatum. So this was one of the earlier studies we did, also in collaboration with Brookhaven Group and Nora. And basically what we found was low dopamine transporter activity and D2, D3 binding. And this is the D2, D3. And you see it here, not only in the striatum, but you see it extending out here into the limbic system. And this is, it's graphed out on the bottom. So controls in ADHD, lower density, and you can see it. You can see all the brain regions, and significance is marked here. Robust in caudate, but quite prominent in amygdala here and hippocampus. And it turns out that increased amygdala activity and amygdala prefrontal connectivity is not only characteristic, is importantly affected by medication. So Jonathan Posner in a small n fMRI study, but very interesting, showed higher activation of the amygdala and greater amygdala prefrontal connectivity in youth relative to controls when subjects were exposed to emotionally evocative stimulant. And this difference was greatly reduced by administration of methylphenidate. And so going back to our model of emotional dysregulation in ADHD, what does this mean? Higher activation of the amygdala would be greater emotionality, and a greater amygdala prefrontal connectivity might or might not be a good thing. It depends on how you're looking at the connectivity. Is it if it's connecting, the direction, if it's connecting prefrontal to amygdala, you're talking about inhibitory control. But what you typically focus on here is transmission of the signal from amygdala to frontal cortex. And so the greater connectivity is not necessarily an advantage. Both improved by drug treatment. Now, not everything that goes on in the limbic system is related to emotion. There's also such a thing as the cognitive control of emotion. And that was shown in this study that Kurt Schultz led from our group. And what is shown here is that, and this was a study with 25 adults with ADHD who were scanned twice. With fMRI, they were performing an emotional go-no-go task after 3 to 4 weeks of treatment with lisdexamfetamine or Vyvanse, and also 3 weeks off medication, which was a combination of placebo and washout or washout before the trial. And what you see is that LDX Vyvanse was associated with increased right amygdala activation and reduced interactions with orbital aspect of the left inferior frontal in response to sad faces. Sad faces is where the action always is in this particular version of the task. But the interesting thing here, you'll see on the bottom of the bottom right of the slide, is that the association here, the relative gain in right amygdala activation in response to sad faces with drug was correlated with a reduction in symptoms of ADHD. So here you have the brief emotional control scale. So this was not related to emotional control. It was related to ADHD symptoms and attention, which we took to mean that it wasn't what the drug was doing here was helping you detect the sad face, and so reading the emotion, the cognition of emotion. Now, I mentioned a default mode network before, and this was studied by Brad Peterson at Columbia, showing the effect of methylphenidate in increasing suppression of the default mode network while doing fMRI, task fMRI. So you do suppress, and you want to suppress it more. And so that would be a positive effect of the drug. And you see it here in the red box on the slide, and the areas are identified below. And the implication of this is that the brain can work more efficiently when you suppress default mode activity. You don't have to drive it as much. And this particular slide from a study that Nora Volkov did in Brookhaven, we weren't part of this slide, this study, looked at glucose utilization in adults who were doing numerical calculations. And they had greater glucose utilization on placebo than methylphenidate, meaning that the brain was functioning more efficiently on methylphenidate, and it didn't have to work as hard. And we'll come back to this because it becomes important to our model. I'd like to walk you through this slide in great detail, but I don't think I really have time. But it shows a really important interaction between default mode network modulation, motivation, reward, and inhibitory control. This was an fMRI study that looked at a motivational incentive paired with a go-no-go task. with and without drug and controls. Basically, what it showed is that in a high incentive condition off methylphenidate, the brain looks pretty much like it does in a low incentive condition on methylphenidate, meaning that that you probably don't need as much methylphenidate in a high incentive condition as a low incentive condition. I actually explained this to one of my patients yesterday who couldn't figure it out, why he was able to take a lower dose on a project that he really, really was into. And so this, I think, is really interesting. And you can see in the high incentive drug condition, you basically are starting to replicate what you see in the controls, which is really, I think, fascinating. Finally, I just want to say that a lot of recent studies in the area have begun to look at a larger set of brain connections in relationship to ADHD and drug treatment of ADHD. And this one highlights the fact that basically what methylphenidate is doing, what stimulants are doing, is improving broad network connections across multiple networks. And so focusing in on one or the other is useful, but really the broader view may well be more important. And you can see the ones that were implicated, that were strengthened by drug, importantly, the attention network and executive function network and et cetera, salient network. And so what do stimulants do? They bind to dopamine and norepinephrine transporters. They increase synaptic dopamine and norepinephrine. They modulate activity in frontal striatal network. They suppress default mode activity, quieting noise, enhancing signal, allowing the brain to work more efficiently. They alter limbic prefrontal connectivity, so they help modulate emotional control. They enhance activity in reward and salience networks. They increase motivation and sensitivity to reward. They make tasks seem more interesting that are boring, that people don't want to do. And they strengthen network connectivity more broadly. All right, we're going to move on to non-stimulants. I'm going to have to pick up the pace a little bit. Stimulants are extremely effective, but there's poor response or tolerability in some patients. There's suboptimal response in many patients. Time action effects are problematic with stimulants. Stimulants can be relative or labeled contraindications for some comorbid conditions. Some patients won't take them. Some doctors won't prescribe them. And there's definitely risk for diversion or abuse of the drugs. They're Schedule II drugs. So there's been a lot of interest in developing non-stimulant alternatives for ADHD. Now, atomoxetine, I told you, selectively binds to norepinephrine transporters, not so robust here, and the dose effects are not as robust. Really, the norepinephrine transport ligand is not as effective as a dopamine transport ligand. And so that's one of the reasons that we know a lot more about the role of dopamine in ADHD than we do about norepinephrine. I mentioned it, there's a little bit of activity at the serotonin transporter as well, but it's quite low. And one of the interesting things is that you would expect atomoxetine to increase dopamine level, norepinephrine level. I always mess up this slide. You'd expect it to increase norepinephrine levels in the prefrontal cortex. You'd expect it to increase norepinephrine levels in the brain diffusely. But you wouldn't necessarily expect an increase in dopamine in prefrontal cortex. But look, here, this is a microassay study in rats in which atomoxetine and methylphenidate are injected and neurotransmitter levels are measured. And you can see that you get the same picture for atomoxetine as you do with methylphenidate. And the reason you do is that norepinephrine transporters are plentiful in the prefrontal cortex and dopamine transporters are relatively absent. And so dopamine reuptake is achieved via norepinephrine transporters. And so it is absolutely correct to say that atomoxetine has direct effects on dopamine and prefrontal cortex, although it does not have effects on dopamine and striatum. And here you see that this effect on dopamine is only seen in the prefrontal cortex. You don't see it in the striatum nucleus accumbens. So this is an early study done in healthy adults by Sam Chamberlain with Trevor Robbins in London, showing that atomoxetine increased right inferior frontal activity, very similar to what you saw with methylphenidate. And this is a stop signal task. And so you see the activity is associated with successful inhibition. And that's really where it's most important. And you can see it's selective to successful inhibition. Now, atomoxetine is not as effective as methylphenidate on average. It's a really big comparator study funded by Eli Lilly. We were one of the sites in it. And I was one of the lead investigators in it. And this is over 500 kids treated with atomoxetine, methylphenidate, and placebo in a 2-to-1 randomization. And the outcome measure here is percent responders rather than symptom change, but you can see it here for all patients. And you can see both drugs do a lot better than placebo, but methylphenidate does better than atomoxetine. And that is mainly carried by the ones that are previously treated. You see the same relationship, but a much smaller effect that isn't significant in the group that's stimulant naive. This figure doesn't appear anywhere except my slide decks. It wasn't taken from a paper. I made it actually after several years ago to describe a few lines of text in the paper to show you that there's really a relative bimodal response to atomoxetine in pre-marketing clinical trials. This is non-response of less, I call it non-response, change in symptoms of 25% or less. And considering the placebo is getting you 15 to 20 or plus, I call that non-response. So you see quite good response and basically relatively poor response with not a lot of people in the middle. So this is exactly the kind of drug that screams out for the need for a personalized treatment approach, because you want to identify these people and not these people. And by the way, this is a pretty high level of non-response. So we did this study that we call MACRO, which is an acronym that stands for methylphenidate atomoxetine crossover. It is a very large and torturous study to do. It was done here and in Chicago with my good friend and collaborator, Mark Stein, and with a lot of good friends and collaborators here, but notably Kurt Schultz doing the imaging piece of this. This is just a schematic of the study. It was no placebo in the study. We randomized for order. We had a 2-week washout in between, but people knew they were on washout as placebo washout, so they wouldn't get out of the habit of taking drug. And there you have it. And then afterwards, we were able to get funded to do first a pilot and subsequently a larger R01 to look at the impact of drugs on MRI. These are the clinical findings. They actually replicate the Lilly findings. I don't want to belabor this. We have more expectancy in the first block, so the Cohen's D is lower and doesn't quite reach significance. We powered at about 0.2. You can see more robustly here. You do have a little bit of carryover, but not too much, and it doesn't differ by drug. So that looks really quite good, and it basically shows what we know. What about the imaging study? Okay, so these are 18 subjects pre and post treatment with methylphenidate and 18 on atomoxetine, task MRI, and this is basically a, and what you see, it's a go-no-go task, and what you see is common effects here and divergent or unique effects here on the right side of the slide. So common reduction in activation in motor cortex, and divergent effects in inferior frontal ACC and PCC, posterior cingulate. And so what does this mean? Well, very, very consistent with our model of atomoxetine driving cortical activity and the attention signal, and methylphenidate increasing efficiency in how the brain works. We think that posterior cingulate default mode activity here is really key. And why do these other areas go down? They don't have to work as hard. Here, why does posterior cingulate go up here with atomoxetine? We're not sure. Some people have found increased atomoxetine activity in default mode, but we think it can. We think this is driving the response, and we're involved in some analyses now with that greatly expand the sample that will allow us to test the model. I'll just tell you that Susan Gao in Taiwan did a similar study, different task, and basically found the same regions having divergent activity, although in a different direction, possibly task related, possibly other things, possibly the analytic platform. So again, some convergence of findings here. We wanted to then look at the specific predictors of this to look at whether the fMRI profile could predict differential response to methylphenidate and atomoxetine. And we had the hypothesis that differences in striatal activation off drug might predict differential response. So this is a second analysis from the same study, 36 youth who completed treatment with both medications for 6 to 8 weeks. Obviously, a lot of them were in the first publication, but not, it's probably about 3/4, because in the first one, you just had to do the first block, and here you had to do both treatment blocks. And we examined both main effects, which would be a profile associated with response for each drug, and interactions, which would be associated with differential response. Here are the main effects. You see a main effect for atomoxetine in motor cortex. We had a finding for atomoxetine in motor cortex previously. And basically what we're showing is that motor cortex activity increases as you're getting improvement with atomoxetine. And you see the R here is pretty good. I mean, it doesn't explain the whole phenomenon. It's about a third of the variance accounted for. This is the really most exciting finding from the study, which is the differential response finding. And this finding shows that increased baseline caudate activation was predictor of superior response to methylphenidate over atomoxetine. Here you see the brain map, and here you see the heat map. The heat map basically just is a 3-dimensional map. So the y-axis shows you change score improvement for atomoxetine, and the x-axis shows you improvement for methylphenidate, and the colors show you brain activation in this region. And what you see here is, the highest brain activation was over here. And what do you see? You see the people that had that had really very, very robust responses to methylphenidate and very little response to atomoxetine. 75 to 100% symptom change. We'd say 50% is a robust responder, maybe even called a remitter. And here you have it just about, it pushes up a little bit but 25% or lower, almost all of it for atomoxetine. So atomoxetine increases synaptic dopamine in prefrontal cortex and norepinephrine diffusely. It drives prefrontal activity, which we think increases attention and responsiveness to signal. It enhances inhibitory control via activity in inferior frontal gyrus. It doesn't really have a direct effect in the caudate or ventral striatum, which, at least in our hands, which suggests that it should have minimal effects on motivation and reward. There are uncertain effects on default mode network. In our hands, we don't think it does. Others think it may. So I'd say maybe task dependent. And there are notable similarities and differences for methylphenidate. I'll try to take 5 minutes to finish up and talk to you just quickly a bit about the alpha-2 agonists. This beautiful cartoon was drawn from, taken from a paper from Amy Arnson's lab in New Haven. And it shows you the cellular effects of the alpha-2 agonist that she and her lab have mapped out. They've worked extensively with guanfacine. And what they show you is that guanfacine plugs up this ion channel that when it's open, prevents a signal from going forward, and when it's closed, allows postsynaptic transmission of a signal. And you can see that this postsynaptic receptor modifies neurotransmission of other neurotransmitters. Here, it's an excitatory glutamate neuron. And I mentioned about the postsynaptic effects because the alpha-2 agonists also have presynaptic effects, and a lot of people thought that that's how they carried their effect, but it wasn't until this became known that we can see that most of the effect of the drug is postsynaptic, of the drugs are postsynaptic. This is from a study that Suzanne Clerkin did with our group. Kurt mentored, looking at, I think I'm being told I have to wrap up, but let me see. Oh no, I'm being asked a question. I'm gonna put that on pause. How do I make that go away? Okay. And this is healthy adults, basically young adults, a lot of Queens College students who were scanned twice, once on placebo and once after 1 milligram of immediate release guanfacine. And they did a cued alerting task. It was basically a target detection, and they had to respond, and it was basically measured reaction time. And what they found is that with the cue, they and you have increase in, let's see, I can show it to you here, guanfacine relative to placebo, a smidgen here, but most of the finding here is in DLPFC. It's exactly as this drug was drawn up to work. It's exactly what they found in animal models, and it should suggest a drug that works really well for working memory and cognitive control and executive control. But it's interesting that what we have learned, why is this not advancing? Why is my thing stuck? Okay. Is that guanfacine is not as good for attention and cognitive control as the stimulants, and maybe not, and at least in the studies of guanfacine long-acting, there's a little bit of an effect size superiority for hyperactive impulsive symptoms than inattention. And basically, people give this drug more for behavioral control than cognitive control in ADHD. And you can use it for adults too, for restlessness and things that they may not come to treatment for that may well be very important. The question is, why is this? And a little more work from Kurt and our group on the effects of guanfacine using the face go no go task. Again, looking at the SAD face here, showing that guanfacine altered the connectivity between amygdala and inferior frontal gyrus in association with improvement in negative bias in response to SAD faces. So we think that guanfacine actually improves emotional control, and emotional control may, as we know, oppositional symptoms, which I showed you in the slide before, are very heavily influenced by emotional control as well as cognitive control. And so we think that that may be the reason that this drug has a very good effect on emotional control. We also did a drug placebo study looking at guanfacine, and it's a pilot. Basically, we use CGI here rather than symptom change because we had too high of a symptom change on placebo. But what you see is basically that guanfacine had an effect at mid-cingulate cortex. reduced activation for guanfacine compared to placebo there, and into left posterior PCC. And it's interesting, it's very similar to a finding from George Bush early on with methylphenidate. So I would count this as mainly a common effect with methylphenidate. So to summarize, guanfacine binds to postsynaptic ion channels and facilitates signal transmission. It increases activation in prefrontal cortex. It enhances alerting mechanisms. It has effects on attention and executive function, but they're less robust in humans than the effects are for hyperactive and impulsive symptoms. It decreases limbic activity and limbic prefrontal connectivity, and potentially modulates emotional reactivity and emotional dysregulation in ADHD. And this decrease in activation in mid-cingulate may represent a common mechanism with stimulants. I'm just going to move to the take-home messages quickly. Just to say that ADHD is a multifaceted neurodevelopmental disorder that has a strong biological basis. And the expanding conceptualization of the disorder highlights several important clinical domains of interest beyond what we tell you in DSM. The effective treatments for ADHD impact multiple brain regions, including attention and executive control, default mode, activity, reward and motivation, salience, and emotion regulation. The effective medications have both common and unique effects. Unique effects provide a rationale for combination pharmacotherapy and a neurobiological basis of differential response. Are there biomarkers of differential response? Well, we're very intrigued by our findings and those of others, but we would have to say not yet. These are interesting preliminary data. Certainly you wouldn't want to recommend that people get MRIs. And the clinical observations regarding a broader ADHD phenotype line up really well with findings from neuroimaging studies. So the current definition of ADHD, in my opinion, which maps most closely onto this restrictive frontostriatal model, isn't fully adequate. And I'm going to stop there. Joe's going to give me the hook anyway if I don't stop.
Thank you for a great talk. We're at the top of the hour, and I already see some people are moving to the next talk, but maybe if you want to, there's a couple of questions in the
Sure.
chat box. I guess I'm reading from the bottom up here, but Nigel Kennedy, thank you for the great talk. Wondering whether practitioners should lower the threshold for starting a stimulant because he's concerned that it's undertreated.
It's vastly undertreated. Of course, everybody who gives a talk advocates that everybody should be very interested in the thing that they do, and I'm certainly not any different. But here's why, even if you're not like an ADHD maven, you should really think a lot about identifying and treating ADHD in adults. People that ADHD is commonly represented in people with depression. And if you think about it, the low motivational state in ADHD may share clinical and neurobiological commonalities with the anhedonia of depression. And we know that ADHD is overrepresented in treatment-resistant depression, and that treating ADHD can actually be very helpful for that population. I guess lining up with an old finding that amphetamine was often used as an early treatment of depression in the elderly. Let's go to the second one. What factors would I consider? Oh, that's a long discussion about treating ADHD and bipolar disorder. Stabilize the bipolar disorder first, and then definitely look at the ADHD, because a lot of people with bipolar disorder, the vast majority of adolescents with bipolar disorder have ADHD. Do the medications make long-term neurobiological changes that may resolve some of the ADHD symptoms? Well, one would hope so, but we know that typically when we withdraw medications for ADHD, people don't maintain their benefit. Now, they could make long-term changes that aren't maintained when you withdraw the drug, because there can be other changes that serve to maintain homeostasis. By the way, some of the neurobiological changes that occur don't really take that long to occur. Some of the neuroanatomical changes that occur at the receptor level probably occur relatively quickly. So, and you get upregulation of DAT and downregulation of D2 and D3 receptors. So you may actually have people get a little worse when you take them off stimulants, even after a moderately short trial. There is some interest in white matter and changes in white matter with stimulant treatment over time. We'd love to be able to show that this is the case. Most often people who've looked at changes in the brain with stimulant treatment have wanted to focus on whether stimulants damage the brain. I think that's really an unfortunate way of looking at the problem. Of course, both questions have relevance.
Yeah.
I got those three. Are there more?
Well, why don't you take the last one? Nigel had a second one.
Oh,
Practice question. What are your thoughts on neuropsychological testing for diagnosis? Should this be done routinely in every patient?
so I think the simple answer to that is no. And I hope not to get in too much trouble with my neuropsychologist colleagues who I love, admire, and value very much. Now, Russell Barkley says emphatically that neuropsychological testing is not needed for ADHD. That I would say is should be moderated. Now, one of the reasons assuming I'm right, it would be good that neuropsychological testing is not needed to make a diagnosis of ADHD is that neuropsychological testing is expensive. It's not easy to get. What is it definitely can tell you about ADHD, but there is no test that actually is required to tell you whether you have ADHD. What neuropsychological testing will do is present a robust profile of relative strengths and weaknesses in functioning, and it is required for getting accommodations in the educational setting and sometimes in the occupational setting.
Okay, I think we should probably stop there. Thank you very much for a great talk. A lot of very excited, interesting participants. And thank you for doing this. And yeah, we'll see.
Thanks for inviting me, and I'm happy to continue the dialogue with anyone who's interested, of course.
Yeah.
Bye.
Thank you all for joining. There'll be another, we'll have another one of these virtual seminars in 2 weeks. Thanks, Jeff. Bye-bye.